are some risk factors which favors the occurrence of preterm labor. First, regarding previous history, if any previous history of any induced or spontaneous abortion is there, or if a multi-para previous history of preterm labor, and also in artificial reproductive techniques, if the lady has conceived through artificial reproductive techniques and recurrent I told in the previous class that any kind of infection will accelerate the production of prostaglandins. Prostaglandin causes the initiation of labor. So if a lady is having any kind of infection during or before 37 weeks, that may accelerate for the formation of prostaglandins, which will cause the onset of labor. And also malnutrition and maternal stress also precipitates the preterm labor. Preterm labor. Next, this is regarding the previous history. So there are some complications during the pregnancy that will lead to preterm labor. First one is we can categorize it into maternal, fetal, placental causes. Maternal causes like diseases in the pregnancy, like preeclampsia. Preeclampsia is a hypertensive disorder. Then APH means antepartum hemorrhage. If that lady is having hemorrhage during after 20 weeks, it is called APH. Then premature rupture of membranes. Rupture of membranes itself is the indication of onset of labor. So if premature rupture of membrane is there, that will lead into early labor. Then polyhydramnios. So there will be mechanical stretching due to increased fluid volume inside the uterus. This mechanical stretch will cause initiation of labor. Then there's some uterine anomalies like cervical incompetence. It is the most common cause. If cervix is not compactable so as to withhold the pregnancy, there will be early dilatation leading to labor. Next is any kind of malformations of the uterus. Then some disorders like surgical or medical disorders. And as I tell, any kind of infection will cause prostaglandin synthesis. So in fever also, it's a kind of infection leading to prostaglandin synthesis that will lead into preterm labor. Next, some fetal factors like multiple pregnancy. If multiple twins or mostly there will be twins. If twin pregnancy is there, the uterus size will be enlarged more. So around 37 or before 37 weeks, it cannot stretch further. So there will be formation that will lead into preterm labor. Then congenital anomalies, if any intrauterine death of the fetus is there. So these all will cause the preterm labor. Next, some placental causes like infarction. Infarction means separation of normally situated placenta, like or abruptio placenta, or thrombus formation in the placenta, that is thrombosis. Placenta previa. Placenta previa is nothing but the placenta is situated in the lower uterine segment. So that will cause early separation. So these all causes in the during the pregnancy will lead into a preterm labor. Most of the times, all the times, we cannot say, most of the time that will precipitate preterm labor. Next, some iatrogenic causes during the obstetric or due as a complication of obstetrics that will lead into preterm labor. Next, some idiopathic causes. So these are the causes of preterm labor. Normally, these are asked in exam, so you must study thoroughly. Then the diagnosis. How you diagnose preterm labor? So in as like normal labor, whatever that will be seen before 37 weeks, like regular uterine contractions that may with or without pain, and the cervical dilatation, that is cervical dilatation 2 centimeter per hour. Then effacement that all we dealt in the previous class, that is taking up of the uterus lower cervical fibers into the lower uterine segment. So effacement, if it is 80% effaced, so the delivery will occur within 24 hours. Then length of the cervix we can measure. When a patient comes to us, we can measure the length of the cervix by transvaginal scan, if there is funneling of internal os, like that a sign will seen. There will be dilatation of the cervix from above to downwards. So it will be seen as a funnel shape in the USG scan. So if it is there, it is likely to have she is likely to have a preterm labor. Then a pelvic pressure, the signs like physical signs like backache, vaginal discharge, or bleeding is the preterm labor can occur. If the cervical length is more or less than 30 mm, it is sure that within 12 hours the labor will onset. So there are some, we can categorize the predictors into 3 categories. First one is clinically how we can assess. So it's from the history and the symptoms above said, and if it is a case of multiple pregnancy, we should suspect of preterm labor. Then presence of genital tract infection. Then biophysical profiles, if you assess the uterine contraction, if the 4 contractions are there in 1 hour, means there stands for preterm labor. And Bishop score is nothing but it is altogether the cervical scores like dilatation, effacement, etc. has been scored. So if it is more than 4, you can suspect of preterm labor. Then if the cervical length is less than or equal to 25 sorry, it is mm, so we can there is a molecule called fetal fibronectin. If it is present in the vaginal discharge, we can say that it stands for a preterm labor. Okay, so this was regarding diagnosis. Then how you manage a patient who comes with signs of preterm labor. The primary concentration has to be given in the preventive aspect. So we have dealt with regarding the high risk factors. If a patient is having these all high risk factors that which is in the table, we have to monitor the patient and we have to screen the patient. So early detection, and for example, I say if a case of cervical incompetence, there is a procedure called cervical encirclage. It is nothing but the cervix is sutured so that the dilatation would not occur. So like that, we can early prevent some conditions, not all. If preeclampsia is there, we have to monitor the patient and we have to make the BP in a normal pattern. So we can prevent the preterm labor. Next, in all cases, we cannot prevent. There are some sudden onsets. So if it is not contraindicated, some cases, if there is a sign of preeclampsia, if there is BP is continuously shooting up, we should not arrest the labor. So yes, it will harmful to both fetus and mother. So in the cases where it is not contraindicated, we can opt the managements like complete bed rest to the patient, then adequate hydration should be given, then prophylactic antibiotic should be given. If any case of infection, we should start prophylactic antibiotic, and as I said, cervical encirclage should be done. Then tocolytic agents. Tocolytic agents means which prevents the uterine contraction, that can be given. Then MGFO4 is a drug that enhances the fetal lung maturation. If at all labor occurs, we have to make the fetal lung matured so that it can have an infant survival. So MGSO4 is given for that. So so these can be given so as to arrest. Next is actual management. So there are short-term therapy we will take. So that is, we will give some medicines like glucocorticoids and MGSO4 so as to mature the fetal lung. So at least about 40 hours we will give that medicine so that somewhat we can make the fetal lung matured and we can go for a delivery. So and also it is firstly it is done for fetal lung maturation. And the second thing, if that patient came to a secondary or primary care unit, so as to till that duration we have to arrest the process of labor. So we are giving a short-term therapy. Then managing of during labor, we should care very thoroughly so as to prevent asphyxia. There are chances for fetal lung to be immature and there will be signs of respiratory syndrome in fetus. So this we will deal in the next slides. What is respiratory syndrome or fetal distress? That all we will deal. So there are chances if for in a baby with preterm labor can have this. So you have to take care of urinary care unit with sufficient equipments with a skilled person obstetrician. We have to conduct. So this is all about, and after delivery, the baby should be kept in NICU, neonatal intensive care unit, so as to make it its organs to be mature. So these all regarding the preterm labor, we have dealt with the causes, then how you diagnose case, and how is the management. So next I am going to prolonged or postterm pregnancy. What is meant by prolonged or postterm pregnancy? Yeah, previous case was preterm, and this is direct opposite to that. Here the pregnancy continues beyond 2 weeks of EDD, expected date after 2 weeks of expected date of delivery. That is after 40 weeks. If delivery, even after 40 weeks, if delivery is not occurring, we'll say that it is postterm pregnancy. So what may be the etiology, reasons for postterm pregnancy? First one, it is all in 90% of cases, it is due to wrong dates. If in case of an irregular lady with irregular menstruation, we cannot exactly fix the date. So in such cases, we can say that the preterm postterm pregnancy can occur. Next, some biological variabilities is also a cause. Next, and some fetal factors like congenital anomalies. That in that cases, postpartum pregnancy may occur. Then some placental factors, as like in the previous class, I told that in the later pregnancy, the level of estrogen hormone will rise, and there is a decreasing the progesterone level. So there is an alteration of estrogen during the onset of labor. So if estrogen level is not increased, means the ratio is not going to be changed. So estrogen will cause the oxytocin to release. Oxytocin is causing the uterine contraction. So likewise, what happens? The uterine contraction will not occur due to low estrogen levels. Next is how you diagnose. The main thing is you have to take a thorough menstrual history, and weight recording. Weight should be monitored in a patient so that we can assess gain of weight during pregnancy. And on an average, in a normal pregnancy, there will be 11 kg weight gain in a mother. Then we can assess with fundal height, that is the girth of abdomen. Then we can assess with the fundal height chart. Next is internal examination has to be done so as to assess the ripening of the cervix. If the cervix is dilated or a space like that, we have to assess. Then we can know that it is how we can know whether it is a postterm pregnancy. So next is the investigation. What all investigation that can be done so as to fix the postterm pregnancy? First one is we have to confirm the fetal maturity through TVS and amniocentesis. It is nowadays it is very rarely done. Next is to detect placental insufficiency. In postterm labor, the main problem is with the placental insufficiency. During the later trimester, that is in the late months of third trimester, there will be placental maturation. So we will say you might have seen in the scan reports, that is grade 3 maturation of placenta. So if it is after 40 weeks, means there will be improper uteroplacental circulation. So the baby will be getting less amount of not less amount, there will be hindrance in the circulation that will cause placental insufficiency. So the baby might the fetus might be in trouble. So we have to assess for that. Doppler ultrasonography is done so as to know the velocity in the umbilical artery. Next is then events of the baby. Normally in postpartum pregnancy, the skin of the baby will be wrinkled and the weight will be more than 3 kg. And there will be the liquor amni will be scanty. And as I said, the aging of placenta is visible. Then diminished quantity of Wharton's jelly. That Wharton's jelly is present over the umbilical cord. So it's will reduce. Then what can be the complications of postpartum pregnancy? First thing, as I told, placental insufficiency is a major cause, and there are more chances for the fetus to pass meconium. Meconium is nothing but the fetus. So when it passes, the amniotic fluid becomes stained with meconium, and the fetus may engulf that. So it will lead into meconium aspiration syndrome, we will say. We will tell. So there are chances for that. It is another complication. And during the conduction of labor, the fetal hypoxia may occur because the placenta is insufficient. So the baby is getting less oxygen. So the baby may go into hypoxic state, and that will precipitate the acidosis. And there will be cord compression also. So these all things can occur during labor. Then following birth, as I told, the chances for meconium aspiration is there. Then hyperglycemia. The baby is getting less amount of fluid because of placental insufficiency. So its chances for hyperglycemia. The glucose level in the blood goes down. So these are the complications. Then management. In uncomplicated cases, we must go for induction. So when the patient is come to you with a postpartum pregnancy, directly we can opt for induction in case of normal pregnancy, normal uncomplicated cases. If it is complicated, you'll just go for a LSCS section. So this is regarding postpartum or prolonged pregnancy. We dealt with the definition and its etiological factors, then the investigation, how you manage during labor. Next is, actually, the next topic is cephalopelvic disproportion. So before moving to that, you must know what is the cause for disproportion. So that is the contracted pelvis. When the pelvis is not adequate, the pelvis shape is not adequate so as to accommodate. We have, in the previous class, we have dealt with the mechanism of labor. So as to occur a normal mechanism, the pelvis must be adequate so as to incorporate the head of the baby, head and the rest of the parts. So moving to contracted pelvis. Contracted pelvis is nothing but it is an alteration of shape and size of the pelvis so as to alter the normal mechanism. As I said, in an average sized baby. Normally, there are 4 variations in the pelvis. Actually, this thing you all have studied during your first year anatomy. There are 4 types. First is gynecoid, that is common, normal. Anthropoid is in this. See my cursor. This is the gynecoid type. That is the oval. The pelvic inlet cavity is oval. So the baby mechanism of normal labor can occur. Next is anthropoid, nothing but anterior posteriorly oval. Anterior posteriorly oval means the anterior posterior diameters are more. Next is platypoid, means it is transversely wide. And next one is android type. See this in the third picture. This is an android type. This is causing mostly this is causing contracted pelvis or cephalopelvic disproportion. See here the cavity is almost a heart shape. That is a triangular shape. So the baby's head is globular. It cannot pass through and normal mechanism cannot occur. So this is regarding the 4 parent pelvis types. Another causes for contracted pelvis is nutrition and environmental factors. You might see in the pictures of African child or women. In malnourished women, we can see the alteration in the pelvis size and shape. So in such cases, we can say that it is a contracted pelvis. And then some diseases like poliomyelitis and rickets also, there will be reduction in the pelvic cavity size. Then other developmental defects like Naegele's pelvis, Robert's pelvis, etc. These are it's nothing but the normal shape of the pelvis is not maintained. So this is regarding the contracted pelvis. So in this chart, I have told us the red mark which are there. You have to study that. I have told all these things. So you go through that. For a UG level, what is the contracted pelvis and what are the reasons. That is enough. For PGs, you must go in detail regarding the various dimensions also. So next, obstetric outcomes. Normally in the three types like gynecoid, anthropoid and platypaloid, normal delivery without any difficulty will occur. But in case of an android pelvis, there is chance for perineal injury, and also some, in mostly it will lead to cephalopelvic disproportion. So how you diagnose a case of contracted pelvis? So before the labor, before starting the labor or fixing the labor date, if a obstetrician must diagnose the contracted pelvis. So it can be medical. We can go through the history. If any medical history of fracture or tuberculosis or rickets in the childhood is there, you should suspect for a contracted pelvis. Then physical examination has to be done. Then if a lady is with height less than 5 feet is likely to have a contracted pelvis. Whole body length is reduced. Likewise, the pelvis length will also reduce. So in such cases, there is chance for a contracted pelvis. Then other things are abdominal examination. If the abdomen, when you see the inspect the abdomen, if it is a pendulous in shape, you must suspect for a contracted pelvis. Then another method is there. It is called assessment pelvimetry. Oftenly it is asked for Viva for UGs, but PGs it is asked for as a main question. So for PGs must study it in detail. Others, you just should know what is pelvimetry. Then by imaging studies. Nowadays, X-rays are not advocated. MRI or CT scan are done to assess the contracted pelvis. So clinical pelvimetry, it is nothing before the onset of labor, that is after 37 weeks. If we do any vaginal examination before 37 weeks, there may be chances for a contracted pelvis. Sorry, there may be chances for a premature labor. So in them, we will do after 37 weeks. When you do a vaginal examination, so you can assess the pelvis adequacy. So after emptying bladder, the patient is kept in a dorsal position. So station of the fetal head, where the fetal head is lying in relation to the ischial spine has to be noted. Then status of a cervix. Cervix is ripened or dilated or effaced. You assess that. Then with the vaginal fingers, you must palpate sacrum. In a normal adequate pelvis, it will be smooth around labor. The pelvis bone is much enlarged. There is a slight enlargement of the pelvic bone. So the sacrum will be smooth, and the sacrosciatic notch, two finger. There is a video in that. I have attached a video of doing clinical pelvimetry. After this class, you just go through that. So ischial spines are looked for, then iliopectineal lines are noted, then sidewise. If in a normal pelvis, you feel the walls as a, the two walls of the pelvis are seen as are going like a parallel. So that indicates normal pelvis. Then the other things are the pubic symphysis. Pubic symphysis are noted. If it is smooth, round curve, that indicates it is a normal pelvis. If there is an angulation, that is abnormal. See, this is regarding the pelvis. This is the sacral bone. So when you insert, see in this picture, the second picture, you see that two are introduced and the sacrum is looked for. So two fingers are introduced into the vagina and the sacrum is palpated. If it is soft, we can say that it is adequate. It's a sign of adequacy. Then I told the subpubic angle. This is in the third picture, this subpubic angle. So if it accommodates the knuckles of your hand, so it can it indicates it is adequate. So these all the things are normally done. Next, we will another thing is I told. See in the second picture, he is looking for the anterior posterior diameter. It is called diagonal conjugate in medicine. This diagonal conjugate is noted. When you insert two fingers, if the middle finger is touching over the sacrum, it indicates that there is enough space so as to pass the baby. So that indicates a normal pelvis. If it is not touching, that indicates it is a contracted pelvis. So that all things are included in this slide. After this class, you go through that. If any doubts, we can discuss. So this is just clinical aspect I have told. And next thing, this is so as to and make you understand regarding the cephalopelvic disproportion. I just went through the contracted pelvis. This is our today's topic. So cephalopelvic disproportion, it is, as I told, there is a relation between size of the fetus to the size of the pelvis. If they are not compatible, if the baby's head is large and the pelvis is not adequate, if it is an android pelvis, it will not pass through. The mechanism of labor will not occur. So in that case, we say that there is a cephalopelvic disproportion. Then causes of disproportion. First one is pelvic inlet contraction. Pelvic inlet contraction means in the pelvis, the inlet is the part where the head engages. So it is contracted, as in case of an android. So that there is cephalopelvic disproportion, and a middle pelvis is contracted. There is no problem with the inlet, but the cavity inside the pelvic bone is contracted. It is called mid-pelvis contraction. And if the outlet is small, it is called contracted outlet. So these three will cause constitute for the formation of cephalopelvic disproportion. Then how you diagnose a case of cephalopelvic disproportion? Clinically, we told that there are methods like abdominal and abdominovaginal method. That is, clinical pelvimetry is done. As I just told now, the clinical pelvimetry can suggest of cephalopelvic disproportion. Another thing is imaging pelvimetry. You suggest for a CT or MRI scan. You can assess the pelvis size and the fetal head size. So just looking for the proportion. If it is not in proportion, not in a proportion, we can say that there is a cephalopelvic disproportion. The normal mechanism of labor, head will not pass through the pelvic cavity. Then cephalometry through ultrasound also you can do. So this is all regarding cephalopelvic disproportion. Then if in a case of contracted pelvis, what happens to the baby and the fetus during pregnancy? That one must know. Pregnancy, I told the abdomen will be pendulous. Abdomen will be bulged out than the normal, and more chances for a malpresentation is there. The normal head vertex presentation, head will not be the engaging part. It is will be or shoulder, like that the presentation will occur because there is no adequate space. Then during labor, there will be delayed cervical dilatation, or it may lead to a premature rupture of membranes. Chances for cord prolapse is there. Then the labor duration increases because the baby head will not pass so easily. The mechanism of labor is delayed, leading to prolonged labor. And if the labor is much prolonged, that lady may end up into a state of shock. Then puerperal bleeding after or before the expulsion of placenta. The chances for sepsis are there, increased maternal injuries, and also fetal hazards are there. Next, regarding management, mostly very mild case of cephalopelvic disproportion, we can adopt induction of labor. That is, normal labor can be, vaginal labor can be accessed to oxytocin injection, like that. But most of the time we go for a LSCS, that too elective. That if the pelvis is not adequate, previously labor, that is, it is the induction of labor in case of a cephalopelvic disproportion is called trial labor. That is with the use of oxytocin or any other kind of toilet, we go for labor, but it should be under supervision with watchful expectancy. At any time, the complication may occur. There may be arrest of the fetal head in the pelvic floor. So mostly nowadays trial labor is not at all advocated. Only elective LSCS is done in case of a cephalopelvic dysfunction. Next, I'll go to cervical dystocia. Cervical dystocia is also a kind of another abnormal labor or causes of an abnormal labor. It is nothing but the progressive dilatation of cervix will not be there in case of cervical dystocia. Dystocia is abnormal labor. Cervical dystocia means cervix will not dilate, so leading to arrest in the labor or prolongation of labor. There are mainly two causes for cervical dystocia. The prime one is insufficient uterine contraction. Uterine contractions are not much sufficient so as to expel the baby fetus from the womb. Next is malpresentation. If in case of a chin or a bro presentation, the uterine pressure will not be passed sufficiently to the lower segment, so there will not be any dilatation. And also spasm, it is a rare case. In case of a previous injury to the cervix, the muscle will go spasm, it will not dilate. That will lead to cervical dystocia. The cervical dystocia is classified primary and secondary. Primary is seen mostly during the first birth. The internal os dilates, but the external os will not dilate it, and there will be rigidity in the cervix, causes cervical dystocia. Next is another reason for the primary cervical dystocia is insufficient uterine contraction. The uterine contraction will not be much sufficient. Next treatment is the laborers engagement, just the baby is just engaged, will go for an LSCS. Then the baby head has passed into a middle pelvic cavity or to the outlet. There it is. There the dystocia is occurring. We will assess through it through vaginal operative delivery, like forceps we will use, or Vendos, the vacuum extraction of the fetus is done. Next is the secondary cervical dystocia. So when in the previous pregnancy, if there is any injury to the cervix, we'll give a stitch over the cervical region. That will lead into scarring. In such cases, this scarring produces rigidity of the cervix. So in the consecutive labor, there will not be any dilatation of the cervix. That's the reason for secondary dystocia. So there are two kinds of dystocia. First one is primary dystocia. So it is mostly seen during the first labor. Second one is the secondary dystocia. It is seen in multiparous women. So this is regarding cervical dystocia. Treatment all we have done. Next is prolonged labor. We said contracted pelvis, cervical dystocia, all will lead to a prolonged labor. So you must know what is prolonged labor. Prolonged labor is not, it is as like when the combined duration of first and second stage is more than 18 hours. We can say it as a prolonged labor. In the previous class, I told that arbitrary time limit for first stage is around 12 hours in primipare and 6 hours in multipare, and the second stage takes 2 hours in primi and 30 minutes in multipare. So in case of prolonged labor, this combined duration normally it should be around 14 hours in case of a normal labor. If it exceeds more than 18 hours, we say that the labor is prolonged. So it might be due to protraction of first stage, that is cervical dilatation is not proper and leading to inadequate descent of the presenting part. So that is the protraction. The cervical, so I told this in previous class that in normal labor, the cervical dilatation is about more than 1 centimeter per hour. in every hour there will be increase in the dilatation per 1 centimeter. So if it is less than 1 centimeter, we can say that the labor is going to be prolonged. And also I said that we will assess the station of fetal head in respect to the ischial spine in previous class. So if there is the presenting part is not descending, if the station is not progressing, at least it should be more than 1 centimeter per hour. If it is less than this, we see that there is phase. Latent phase is nothing but it is a preparatory stage for uterus. So cervix before the onset of labor. Before the onset of labor, there is a phase called latent phase. In cervix, there is a very slight uterine contraction all. So when it is increased to a duration exceeds 20 hours. Normal duration is 8 hours. When it exceeds 20 hours or more, in primary we can say that there is chances for prolonged labor. If it is 14 hours, normal duration is 4 hours. If it exceeds more than 14 hours, we can say that there is chances for prolonged labor. So the physician must carefully rule out that, and the LS has to be promoted.